Sorry,
Thank
Dr.
you.
Mahesh, in the interest of time, we will probably ask you to go for your money slides.
Sure, sure.
Yeah, thank you.
We all know that how antiplatelets act. Platelets are the main culprit for making thrombus. As soon as platelets come into contact with subendothelial tissue, it starts adhering to it, and then it is activated, and then there is a lot of release of uh, material from the alpha granules, and it causes platelet aggregation. And this all happens very quickly, and this results in formation of platelet plug, which prevents the bleeding. So this is normal homeostatic mechanism, but then this happens at the site of plaque rupture, which causes acute thrombosis, maybe anywhere in the body. So how can you prevent it? So let us know what are the sites of action of current antiplatelet agents. Aspirin is a COX-1 inhibitor, and it prevents conversion of arachidonic acid to thromboxane. Thromboxane binds to the platelet receptors and it activates it and releases more thromboxane so that platelets are activated all over. P2Y12 are the ADP receptor antagonists. They will bind to the receptors at which ADP binds, and they will prevent the, for activation and aggregation of platelets. We all know that GP2B3A inhibitors bind to the receptors 2B3A, which help in aggregation of platelets, and this is the final step in the aggregation of platelet, which results in formation of platelet plug. So if we give this drug, that has the most potent action. This slide has been shown that what are the common oral antiplatelet agents available to us are aspirin, clopidogrel, prasugrel, and ticagrelor. This slide I will not review because it has been shown to us. Aspirin as an antiplatelet therapy. I have showed you, I have discussed that what is the mechanism of action of antiplatelets, and we all know by now since the last 35-40 years that aspirin is COX-1 inhibitor, and it decreases formation of thromboxanity A2, and therefore it prevents platelet aggregation and vasoconstriction. So what are the recommendations of aspirin used for primary prevention? There has been a lot of discussion and debate about whether aspirin should be given to all patients for primary prevention. Results are yes or no, whatever. Let's review them. A person who is around 45 to 79 years of age and has a higher chance of developing acute MI and is male, then you can think about giving aspirin unless there is less risk of development of GI hemorrhage. In the women, aspirin does not prevent acute MI. However, it prevents stroke. Therefore, if you want to prevent a stroke in a lady who is 55 to 79 years of age and the risk outweighs the potential harm of GI hemorrhage, then you can think about it. In the age group of less than 45 years of men and women, there is no need to give aspirin. And if the person is more than 80 years of age, there is no recommendation of use of aspirin. Why this recommendation has come? Because of physician health study. We all know this now study, long back, a very old study of 1989. When it was done in the physicians, almost 22,000 physicians were randomized to aspirin. Followed by 5 years, it showed that it did decrease risk of fatal, non-fatal, or all myocardial infarctions, but it did not decrease cardiovascular mortality because there were higher chances of development of fatal, non-fatal, or total strokes because of more chances of hemorrhage. Women health study, almost 40,000 women were randomized to aspirin or placebo for 10 years. It did show that there was no decrease in cardiovascular events among the women. And therefore, if you meta-analyze all the studies, on the left upper corner, it shows that relative risk of MI in women in men is decreased. Relative risk of MI in women is not decreased. Relative risk of stroke in men is not decreased, and relative risk of stroke in women is decreased. This is what I wanted to say that relative risk of MI in men is decreased by primary use of aspirin, and of stroke in women is decreased by primary use of aspirin. There is no decrease of MI in women, and there is no decrease of stroke in men. Similarly, this is again a meta-analysis of almost 50,000 odd women or 45,000 odd men randomized to aspirin versus placebo for almost 5 to 10 years. The first is a stroke decrease. Women have decrease in stroke, men have decrease in acute MI, but there was no decrease in major cardiovascular events because it balances. In women, there is no decrease in MI, there is decrease in stroke, but in men, there is decrease in MI and there is no decrease in stroke. So everything balances. Therefore, there is a question mark whether we should use aspirin as for primary prevention. This was a study, primary prevention of aspirin diabetics, and it was a 2x2 randomized trial, but it showed that whether you use aspirin or no aspirin, composite primary endpoint is not decreased. Death from coronary artery disease or stroke is not decreased by the use of aspirin. So conclusion was aspirin does not reduce the risk of adverse cardiovascular events in diabetics. Similarly, this was Japanese primary prevention of atherosclerosis with aspirin. Was a trial of 2,500 patients, diabetic, were randomized to aspirin or placebo for 5 years, and it also showed that aspirin does not reduce the risk of adverse cardiovascular event in diabetics. Similarly, aspirin did not decrease cardiovascular events in those patients who have ankle brachial index of less than 0.95. So, antithrombotic trial is collaboration studied, and it found that aspirin is decreasing the risk of acute MI and cardiovascular events. Any stroke is not decreased, but it is increasing major extracranial bleeding. So, conclusion was that aspirin reduces the risk of MI and vascular events at the expense of increased bleeding. Again, the conclusion, the more continuation of aspirin antithrombotic trials for the use of aspirin for primary prevention shows that aspirin did decrease major coronary events, non-fatal MI, cardiovascular mortality, but there is more chance of hemorrhagic strokes and any serious vascular bleeding events. So conclusion was that aspirin is reducing the risk of ischemic event, but with a higher risk of bleeding. As far as secondary prevention is concerned, there is no second thought, there is no doubt that whatever the category of person, whether it was acute MI, whether there was acute stroke, whether it was primary MI, prior MI, whether it was prior stroke or TIA, other high-risk population like unstable angina or heart failure, peripheral artery disease, high risk of thromboembolism, diabetic with multiple risk factors, all the trials showed that it is antiplatelets, especially aspirin, is faring much better than the placebo. So the conclusion was this: aspirin is reducing the risk of adverse cardiovascular events. As far as dose of aspirin, what dose it is decreasing the risk of cardiovascular events, it was a meta-analysis, and it showed that aspirin use, which was almost 75 to 150 milligram, is doing the best. So higher dose of aspirin is not doing any favor, and it does not decrease the it does not help, and it does not improve the efficacy. This was a good trial of current OASIS 7 trial, in which it was a 2x2 factorial trial, double dose of clopidogrel followed by higher dose of clopidogrel for 7 days, and then 75 milligram versus standard dose of clopidogrel, and with high dose aspirin or with low dose aspirin. And the conclusion was, whether we are giving aspirin low dose or we are giving aspirin high dose, higher dose of aspirin does not provide benefit in ACS patients. So these are the guidelines for primary prevention of aspirin, primary prevention of cardiovascular disease, and as far as recommendation of aspirin use, and it shows that low dose of aspirin might be considered for primary prevention of atherosclerotic cardiovascular disease reduction in a person who is 40 to 70 years of age, who are at higher risk of developing ASCVD events, but there is no increased risk of bleeding. That means the person should have more than 10 to 15% 10-year risk of development of ASCVD events, but there should be no increased risk of bleeding. This is for all the person. Low dose of aspirin should not be given on a routine basis for the primary prevention of person who is more than 70 years of age, and low dose of aspirin should not be administered for primary prevention of for the prevention of ASCVD among adults of any age who have increased risk of bleeding. So we can think about giving aspirin to a person who is 40 to 70 years of age and who has a higher risk of development of ASCVD events. Primary prevention in women, aspirin 80 to 100 milligram can be given to a person who, a lady who is more than 65 years of age and has a higher risk of development of events in the next 10 years. If the person is less than 65 years of age, there is less evidence of development of ASCVD scores in the next 10 years, and therefore the level of evidence decreases. Aspirin for the lady who is less than 65 years of age is not recommended. Primary prevention in men, it is a class 1A indication. If the intermediate risk is there, that means there is 10 years risk of development of cardiovascular events of more than 10%, and therefore aspirin should be used in men who have this much higher chance of development of cardiovascular events, and the dose should be around 75 to 150 milligram. As far as diabetes are concerned, there is a lot of controversy, a lot of debate whether all patients of diabetes should be on aspirin, but the final answer is probably no. And who should be on aspirin is that a load of aspirin is recommended for the diabetic with no previous history of cardiovascular disease. That means we are talking about primary prevention, but they should have a next 10-year risk of development of cardiovascular disease of more than 10%, and there should be no increased risk of bleeding. And the level of evidence is 2b2. For primary prevention, aspirin should not be recommended for cardiovascular prevention for adults if the risk is, as I said, less than 5 years, less than 5% in the next 10 years. And if the risk is around 5 to 10%, you can think about giving aspirin. Probably, after discussing with the patients and relative, that there is some risk, some benefit. We all know that for secondary prevention, aspirin is our gold standard, and it should be given to all patients who have known coronary disease, whether that's STMI or non-STMI. Aspirin should be given to all persons following PCI fibrinolytic therapy for STEMI and those who have undergone stenting. For secondary prevention post-PCI, if the person has undergone bare metal stent, which is now a rare commodity, we have to give aspirin for 3 months, and then we can think about decreasing to a single antiplatelet therapy after 3 months, and for 6 months after paclitaxel eluting stent, and for 3 months after ACS. And after 3 or 6 months, aspirin can be given as a single antiplatelet therapy, provided there is no high risk of bleeding. Post bypass surgery, it is a class 1 indication. Aspirin should be continued for lifelong. This is a very important study, and I'll just try to explain to you what it is. Aspirin for primary prevention of coronary artery disease, and what it shows that if you extrapolate these lines, and it comes that aspirin treatment for primary prevention is safe and worthwhile at coronary event risk of more than 1.5% per year. That means more than 15% for 10 years. If the risk is so much high, you calculate ASCVD risk, then if the risk comes as 15% next 10 years, you can think about aspirin is indicated for primary prevention. If the risk is 10%, still it is recommended, but if the risk is less than 5%, the risk is higher of bleeding. There is no benefit of giving aspirin for this patient, therefore it is not recommended. In some other condition, if the person has non-ST elevation MI, we all give aspirin as a loading dose. We add P2Y12 receptor antagonist like ticagrelor or clopidogrel or prasugrel. We have to give oral anticoagulant, and in this condition, aspirin is always our first antiplatelet drug. This is for use of aspirin, ESC guidelines 2017. If the person has undergone PCI for ACS, then you have to give 12 months of DAPT. If the risk of bleeding is not high, if the risk of bleeding is high, then 6 months of DAPT. Similarly, for post-bypass for ACS, same 12 months of DAPT if the risk of bleeding is not high. If the risk of bleeding is high, then 6 months. Same for medical management. If the risk of bleeding is high, DAPT for 12 months. And if the risk of bleeding is high, DAPT at least for 1 month. If the person has undergone PCI for stable coronary disease, then we can think about giving 6 months of DAPT followed by continuing DAPT depending on patient's condition. But then if the risk of DAPT is high, then at least 1 month of DAPT. So finally, antiplatelet treatment for stable coronary disease. As I would say that an antiplatelet treatment significantly reduces vascular endpoints in patients with coronary artery, stable coronary disease. Aspirin remains our drug of choice for secondary prevention. Clopidogrel should be used for patients intolerant or allergic to aspirin as a single antiplatelet. The effect of combination of aspirin and clopidogrel in patients with stable coronary disease is not very well documented. Oral GP2A3 inhibitors were available, but then they increase the risk adverse events and should not be used. Targeting of increased antiplatelet treatment, a high-risk group may be useful. Finally, aspirin remains our drug of choice for secondary prevention of coronary artery disease. Thank you very much.
Thank you, Dr. Mahesh. And I believe I leave it to Dr. Jacktan for quick 5 minutes question and answer if there is time, or he can conclude with his remarks and summing up the whole thing.